Thank you, Julian, and thank you everyone who's here bright and early. And thanks very much to Mars, who gave this great introduction and brought this whole topic into focus. And I'm going to really discuss give you three messages, and also discuss the implications of these messages. So the first one you really heard a lot about is that we have to be aware about the heterogeneity among young adults with HIV, and that they are really comprised of two different groups. One is the behaviorally acquired, mainly through sexual transmission, and the second is the perinatally acquired transmission. And so just a word about what is perinatally acquired for the young people in the audience who may have missed this whole scene of the 80s and 90s. So this results from passage of HIV from the mother to child during pregnancy, labor and delivery, or breastfeeding. And in the pre-ART era, the incidence was about 30 to 40%. But now perinatal transmission can be prevented by ART in pregnant women, and by giving ART to them and a short-term prophylaxis to the newborn. And the incidence has reduced to less than 1% in the US and Europe. But globally, the transmission still continues, and although it's really gone down a lot, it's about 5% or less, mostly in Europe and Southern Africa, and 130,000 new perinatal infected births occurred in 2022. And a little bit more of the history. In the pre-ART era, half of the children with HIV died before they were 2 years of age. But remember, the remaining half survived and grew up, and this is the population that we are really talking about. And of the approximately 12,000 persons with perinatal HIV in the US, majority are now 20 to 30 years old, and the oldest, as shown in the right side, and Mars also showed this graph, and the oldest are in their 30s and early 40s, with several women of childbearing age. And globally, of course, there are many more, about 1.5 million perinatally infected children are still under 15 years of age. And we expect that this population is going to expand, and there'll be more than 5 million in this decade. So it's very hard to come to information, get information about this group of people. And we rely a lot on longitudinal cohorts, such as the ones listed here. And the FACS and the NA Accord are cohorts in North America, whereas the ones listed in blue are all international cohorts. But there are many other sources listed on the right side, of which I think, as you can yourself gauge, Voices of Lifetime Survivors are really one of the most important contributors to the sources of information. And you heard from Mars all the challenges that this population faces. I've listed them all here. I will not be discussing all the social issues, but they also have many aspirations, like all of us, to have happy, healthy relationships, productive employment, parenthood with healthy children, and of course, every person with HIV wants ART-free survival and HIV cure. I'm going to go and discuss a little bit about the clinical outcomes. And that brings me to the second message, that young adults with perinatally acquired HIV are prone to many adverse outcomes. Imagine a child born in 1990 or 2000. That person would be now 24 to 34 years old and has undergone multiple ART changes, maybe many with early ones with toxicities, and many have received several regimens. And laboratory studies and clinical findings point to premature aging, as you heard, with inflammation and comorbidities. And you already heard that young adults with perinatal HIV develop comorbidities of aging. We are all aware of what comorbidities of aging are, as they are listed on the right side of this slide. And we know that people with HIV get accelerated aging. But what's perplexing is that people with perinatally acquired HIV get even more advanced aging. Under age 50, they can manifest them. And the list is there, and you can really see all of it. This pointer is difficult. So, all of these conditions can occur in these children or adults. I really meant adults. So a very fine study was reported earlier this year by the group of Kerry Althoff on the NA Accord cohort. And they investigated diabetes, high cholesterol, high triglycerides, hypertension, and chronic kidney disease in a cohort of perinatally acquired population 8 to 30 years of age. And you can see the trajectories that as they age, the incidence of each of these conditions really increases dramatically. And by age 30, about 25 to 40% of this population have one or more of these comorbidities, pointing out to the need for monitoring and giving behavioral or pharmacological intervention to them. And you all know about this very famous Reprieve trial, and then there are other studies. This Reprieve trial showed that just giving statins to people with a low risk for HIV really prevented cardiovascular events quite dramatically, and this led to recommendations. But these recommendations were for people age 40 and above, because this trial was done in that age group. And this recommendations were for low to medium to high ASCVD risk groups. But what about people under 40? And the only recommendations I could find, I'm not a cardiologist, was that for people 20 to 75 years, only if you have very high LDL-C that you would get high-intensity statins. So clearly there is a need for more research in this area, in lipidomics, and how to prevent cardiovascular disease. And Dr. Dheeraj Fargo is really doing studies like that. Now, a little bit about brain health. This beautiful figure on the right tells you all the potential contributing factors to cognitive impairment in people with HIV. But when it comes to pediatrics, we have to remember that the brain is developing during childhood and adolescence. So, especially in the pre-art era, there was a big impact of HIV on the brain, and we still see impact on cognition and mental health. And we know that brain is a reservoir for HIV, and inflammation influences cognitive and brain health. And now the pediatricians take brain health very seriously. And there are many investigations and intervention strategies shown in the bottom left of the slide, that there are these investigations going on with imaging studies of the brain and CSF analysis, cellular reservoirs, brain organoids, and clinical trials like PEAT 2016. And then there are some cool new mobile devices which are really going to come into play even in this population for diagnosis and treatment of depression. Now, at the center of most of these comorbidities, the main culprit seems to be inflammation. And the question is, why inflammation? And this brings me to the third message, that we already heard about early life events that can profoundly impact life outcomes. We heard about those beeping and going back and forth to the hospital, how traumatic that can be. But there's another factor which is quite important, and that is that early diagnosis and treatment initiation in infancy can really impact what happens later in life. And it has a high probability of reducing all of these bad effects that you see, inflammation, immune deficits, etc. And the mechanism behind it appears to be at least one of the mechanisms, curtailing the HIV reservoir. And how did we come to this kind of conclusion? A study that I was involved in was KARMA. This was a cohort of youth and adults seen in the box with perinatal HIV. They were virally suppressed, and they were, as I said, youth and adults. But they were really in two different groups. One group had had early ART initiation under 6 months of age, and the other group in the bottom had late ART initiation between 6 months to 2 years of age. And so many virological and immunological studies were done. And one of the findings shown here is that by Dr. De Rossi in Italy is that of immune and biologic aging in young adults with perinatal HIV. And they clearly showed that late ART initiation in infancy and childhood results in greater immune activation, immune senescence, and telomere shortening when these people were evaluated as young adults. So that's the main point that I'm trying to make, that early events really are important. Several publications came out of this study and showed the benefits of early ART initiation in infancy. And immunologically, I'm an immunologist, that's what interests me most, is T cells, B cells, NK cells, and proteomics all showed improvement with early treatment initiation. And of course, also the HIV reservoir again, when analyzed many years later, showed difference in the two groups. So the implications of KARMA and these other studies that have been done is that HIV persistence in reservoirs is driving inflammation and adverse outcomes such as premature senescence. And young adults with perinatally acquired HIV, early ART in infancy limits the reservoir size in association with better clinical outcomes. And so just a word about the reservoir, very simplistic. Two major forms of HIV-infected CD4 T cells. The one on the left is productive infection. The virus replicates and the cell dies. And this is what's addressed by antiretroviral therapy. But there's another set of cells, which very few, which are latently infected, where the virus is integrated into the host DNA. And this is the one that is a major barrier to HIV cure. The virus rebounds after long-term ART, even after long-term ART upon treatment interruption. So really we're talking about 2 points of the importance of achieving a small reservoir. One is that the overarching goals of cure strategies is to reduce the HIV reservoir and then let the immune system or immunotherapies do their job. And that early potent ART limits establishment of this reservoir and does two things: minimizes adverse clinical outcomes and sets the stage for cure-related interventions, such as the ones, these are just very few listed on the right side, and they are really ongoing in cure research. And so the take-home points, Lifetime survivors of perinatal HIV are an essential population among people with HIV and need to be recognized and supported. Transition to adult care with monitoring management of aging-related comorbidities is very important, and engagement and education and empowerment of these population will strengthen self-management skills and inform choices for participation in frontline research, including cure research. And these are the components of optimal care and health outcomes, very nicely depicted in this publication by the group of Dr. Foster in England. And many of these points were really echoed by Mars in his presentation, with the addition that, they can teach the provider as much as the provider can teach them. And these are my main acknowledgements, Dr. Alison Agu and Caroline Foster for their input, and the networks that I'm really involved in. Thank you very much for your attention.